voy a presentar a la primera ponente. I'm going to present her in English, so she cannot say, I thought you said nice things about me. So it's really a fortune to have here Megan Cole. She's an epidemiologist at the UK Health Security Agency. And believe it or not, we have here in Gesida one of the top 10 nature scientists. I think you've been told that many times. Top 10 nature science people who have had an impact during the last year in science. And I would see works for the UK Health Security Agency. She started to work on HIV, but as many people transition from HIV to COVID-19. And I will describe her as the explainer-in-chief of the COVID-19 epidemic in UK. She really, if you are on Twitter, follow her on Twitter. She has this wonderful ability of making all these very boring reports with many, many pages of how the epidemic is going in UK. And he translated for making it very simple and very understandable. And I think that's what we need. There is really an overflow of information with COVID-19. And we need people like her that make things really simple. But here, she is here today to talk about HIV. Megan completed a Bachelor of Science in Nutrition Science at Michigan State University and a Master of Health Science at Johns Hopkins University. And now she's completing her doctorate in University College in London. Her doctoral thesis is National Longitudinal Survey of Healthcare Needs and Risk Behaviors of HIV-positive people. She worked from 2019 to 2020 as a civil servant at Public Health England, tracking HIV/AIDS. And in 2020, as I said, she was drafted into the UK government as COVID response. So it's really a pleasure to have you here, Megan, and I'm looking forward to your presentation.
Thank you very much. Is up here?
Yes.
Thank you very much. Thank you for inviting me to come and speak to the conference. This is my first conference in over 3 years. And as Dr. Rivas said, I worked for 10 years in HIV. And then when the pandemic struck, I was drafted in, as were all of the epidemiologists, to work on the COVID response. So I've been doing that for the past 3 years. But it's a real honor to be able to come back and talk about my first love, which is HIV, and the topic I really enjoy, which is about measuring quality of life in people with HIV. So I think it's useful to start by giving a little bit of context of where we are and why this topic is so important at the moment. So we know we've made amazing progress and a lot of advances in HIV, but we still have a long way to go in many areas. So infection rates are falling in many areas, particularly in the EU, but not for all population subgroups everywhere. We also know that deaths from AIDS are falling thanks to the fantastic advances in antiretroviral therapies, but we still do experience preventable deaths in people with HIV. Thanks to the treatments, life expectancy for people with HIV is rising, but along with that comes the other, which is that more people living with HIV are aging and living long, healthy lives into old age with HIV. So what does that mean, living old with HIV? We also have fewer complications that are presenting from immunosuppression, but we have more non-communicable diseases and other comorbidities, including mental health comorbidities, that are presenting in people with HIV, that are affecting their overall quality of life. And while we've had these fantastic biomedical advances, we see much slower advances in terms of societal and cultural norms and understanding about HIV. Stigma still exists. And we know that health systems are very much evolving particularly with looking at non-communicable diseases and managing long-term conditions. So there is the potential that HIV, being seen as an infectious disease discipline, could be left behind in all this. And of course, money is always an issue. So money is available, but there's always less, and with new constraints. So that's the outset of where we are with HIV at the moment. But I think it's useful also to be looking at health in sort of the conceptual idea of health, as has been set out by the WHO 75 years ago. And I think this has aged really well. So we talk about health as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And this is important because just because a person is on treatment with HIV, is on treatment, is virally suppressed, is that the end? No, it's not. They may have many other health and social conditions that are contributing to their poor health, and we must, as a discipline, address those. So generally, we talk about a lot of different aspects of somebody's health and well-being. A nice global way of talking about that is quality of life. But this is a very, very broad and subjective term. So what do we mean by quality of life? Apologies, you probably can't read all the detail here, but it's just to say there are so many aspects of a person's life that feed into their quality of life. There's things like their physical, mental health, aspects like gender and age, but there's also the social side, immediate circumstances like family, friends, work situation. And then there's also the structural environment, so policies and legal legislation. There's also, national stability and security, culture and social attitudes. So it encompasses this very broad idea of many different aspects. But I think when it comes to HIV, it's sometimes helpful to think about an individual perspective. Now here's a quote from a woman, a black African woman in the UK, in her 40s, living with HIV. It's very demonstrative of all the different elements of HIV that can affect quality of life. So this says, I think living with HIV is a bit hard and tricky. Sometimes you just feel down, you feel lethargic, tired. The aches and pains in your body, physical. Yes, it's all physical, mental, especially with lethargy and tiredness, low mood. Yes, I know everyone gets stressed and depressed, but if you are on the medication, it's a different feeling that you're feeling in your body. Sometimes if you take them late, you have the hangover effect. Sometimes for me, I get foggy, forgetful, and muddled. I stopped going to college because I could hear the teacher talking, but I couldn't process what she was saying or what was going on. It was just useless for me to keep going to college. So here we've talked around the mental health issues, we've talked about the physical health issues, and we've talked about how HIV has affected education and employment. And there's so many different aspects that can be affected. So on to the measurement part. So if we know that this is important in the lives of people with HIV, then how do we measure that? We are so used to using clinical measurements to understand CD4 and viral load. We look at diagnostic tests and we look at clinical diagnoses of comorbidities and medication. But in order to understand quality of life, you really have to ask people with HIV. And this is where we come into patient-reported outcomes. So these include any report of the status of a patient's health or experience that comes directly from the patient without interpretation by a clinician or anyone else. So this measures a patient's perception of their own health that either cannot be directly observed or it's not easy to directly observe. So for example, adherence is something that has to be patient-reported in most circumstances, and so you have to ask patients how often they have taken their medication. You can look at adherence perhaps as a proxy, looking at viral suppression, but until you ask a patient how they've taken their medication, you don't know. So there's a subtle distinction as well that needs to be made. In the literature, you'll often hear patient-reported outcome measures and patient-reported experience measures, PROMs and PREMs. So I'll be speaking about PROMs in this, but everything applies to both. So essentially, collecting these patient-reported outcomes, it gives us the opportunity to understand a person's health in a much more holistic and multidimensional way than clinical data alone. So I'll take you through a brief history of PREMs and PROMs in HIV, because this is not a new concept. PREMs and PROMs have been used in HIV since the very beginning. So prior to ART, we used these measures to understand things like risk and transmission. So for example, sexual behavior and injecting behavior, to support opioid substitute use and substitution therapies in people with HIV. In the mid-90s, when we got antiretroviral therapy, there was a shift to monitoring clinical treatment outcomes. So here again, looking at ART adherence, understanding symptom burden, understanding side effects of medication, and now the early point of starting to look at quality of life. In the early 2000s, there was more importance given to treatment choice, so things like side effects and quality of life, and things like sleep, pain, lethargy, to be used to help us select the right treatment for a patient in an environment where you have treatments of similar efficacy. And there's also been a huge development of PROMs that have been used to assess quality of life, fatigue, depression and anxiety, and a wide range of topics. And it's been an area of a lot of research. And actually, in the late 2000s, it became recommended as a secondary outcome to be used in HIV clinical trials, in treatment trials, in order to understand the impact of treatment on overall well-being. And then coming into the most recent 5 to 10 years, there's been this greater focus on long-term health, on the fourth 90. So how people living with HIV cope with HIV as a lifelong condition, and all the general social and personal repercussions of HIV. So we know that it's important to measure quality of life and topics on this. How do we know what to use to measure this? So there's a wide array of tools that can be used. There's some key principles of best practice on how to measure quality of life. One of them is that any tool you select should be validated. It should go through validation studies with people with HIV to ensure that it actually measures what you think it's measuring in the target population, and it does so accurately. There are, and I'll come to the different types of tools in a moment, but there are generic quality of life tools that should also be pre-validated in HIV populations to understand if it works in the population that you're looking at. It should be reliable, so it should be repeatable. It should be able to be used over time, giving a consistent measurement, and it will allow you to show any change that happens over time. And comparability. This is really important when you want to compare with any other populations, either within HIV or outside of HIV. For example, other long-term health conditions or in the general population. So briefly, in terms of the measures that are possible to be used, there are many different routes you can take to selecting the appropriate measure. So you can look at a single item. So this is a single question that can evaluate your outcome. So this might be something like self-reported health status, which just says, how is your health today? And then somebody can say good, very good, bad, very bad. And that's called a single global measure that gives you, it's very easy to introduce, but it doesn't give you much detail. So another alternative is to use a multi-dimensional scale. So in this way, you can have an instrument that has a series of questions that when you put them together, it gives you a score or some sort of measure that takes into account different aspects of the thing you're trying to measure. So you can look at a unidimensional topic, so something like physical functioning or fatigue or sexual functioning. So your questions are all relating to that one topic. Or you can use a multidimensional questionnaire, and this is often used for things like symptoms or health-related quality of life. So you might want to understand aspects like physical symptoms, mental health symptoms. You might need to understand things like ability to function, ability to self-care, to meet your daily needs. So we can use these different tools for different uses. And there is a huge suite of different instruments. We published a review back in 2020 now that tried to collate these measures into one place. So this is a screenshot from that. But a previous review found that in 2017, found that there were 117 different HIV-specific PROMs. And this can lead to a huge challenge for a researcher in trying to distill which measure should be used for which purpose. I don't think there's time now. I would refer you to that paper that we published in 2020 in Lancet HIV for more detail. But broadly, there are two different types of measures. There are generic measures, which are to be used in the general population or for any condition, and there are HIV-specific measures, and these are to be used in HIV-specific populations. I think one thing that can be difficult as well when trying to select the measure is understanding the purpose that you want to use it for. And there are broadly three different types of purposes. One is for use at the patient level. So this is something that you use in the clinic with an individual patient. And you can use this PROM in order to guide the clinical assessment in that appointment with the patient. So you can use this to rapidly identify and focus on the issues that are important to that patient in the clinical assessment. You can also use PROMs at a service level. So this could be in an HIV clinic, or it could even be at a peer charity organization where peer support is being used, or any other service that's for people with HIV. So these can be used to assess areas for quality improvement, to audit how well your service is doing, and also importantly, to ensure that the appropriate referral pathways are in place as needed. So for example, if you do an assessment of unmet need in your clinic and you find that a lot of patients are having issues with obesity or weight management, then perhaps you can set up signposting services and linking in with weight management services to be able to set up those referrals. And finally, there's work at a national level. And this is the area where I mainly work in national HIV surveillance. But this is the collection of patient-reported data that feeds into national surveillance systems. This can be very challenging, but it's really important to complement the surveillance data we have. It's also very important to be able to assess how well your health systems are meeting the needs of people with HIV at a national scale, and identify inequalities, importantly. Again, this is a busy slide and you don't have to read it all, but I think just important as well to note, there are a number of different ways we can collect these. There are things like surveys you can do. So these can be administered by an interviewer, by a clinician, by another person living with HIV. These can be self-administered, so a person can fill out their survey and return it themselves. And there are paper questionnaires and electronic questionnaires. There even now are modules that can be added to the computer systems in your clinic to collect this data centrally. And again, there are pros and cons to different uses. It's important to consider these when you're selecting your method of collection. But I think, in my experience, one thing that also always has to be taken front and center, ensuring that the tool is accessible and acceptable to people living with HIV. Which brings me on to probably the most important slide, I think, in this presentation, which is about involving people with HIV in the step of the process. So it's people with HIV are the ones who are going to tell you what matters to them, not the clinicians and not the national policy people. People with HIV should be involved at the step of understanding what the met and unmet needs are, to selecting the tools, and to ensuring that that data is interpreted in a meaningful way that will actually improve services and policy for them. It also will ensure that we are being as inclusive as possible. That includes inclusion in terms of language and literacy, and in terms of accessibility, like disability for visual impairment, to ensure that there's access for all. So to finish up here, I think I'll just go into a little bit of detail around the UK experience of implementing patient-reported measures, particularly to improve understanding of quality of life and unmet needs. So it was actually back in 2010, so this is 12 years ago now, that really the very early beginnings of understanding the need to collect this data through a small project that was funded by the British HIV Association called Beyond Viral Suppression, which started to bring people together to talk about, should we start actually thinking about this area? Should we start thinking about what it means to live well with HIV after viral suppression happens? And that was really getting a lot of academics, a lot of clinicians, and people with HIV together to start thinking about this. There was in 2011 a consultation meeting run by my organization at the time with people with HIV to try to come to some sort of consensus about what should be measured. It will probably be no surprise that that was almost a complete disaster, because it was very, very difficult to come to a consensus on this type of topic, because the needs of people with HIV are so diverse, and there's no one-size-fits-all best practice tool. So we went back to the drawing board, and we started working on a national HIV patient survey that would collect a range of different questions and different information that could be used. So it was a very, what we call omnibus-style survey, so it covered many different topics, including quality of life, stigma and discrimination, healthcare usage, lifestyle and risk behaviors, met and unmet needs. So it was a very big undertaking. And we ran this pilot in 2012-2013. In addition, we had a national HIV stigma survey in 2016. And both of these topics together, in presenting them back to conferences and different meetings, was actually advancing the discussion about how we could measure this data and the use of this data. In 2017, a King's Fund report, and this is a charity in the UK, came out, which really, for the first time, really emphasized the need to understand so the future of HIV services, within that understanding things like quality of life and good well-being. And then in 2017 as well, we did the first national round of Positive Voices. We collect survey data from 4,500 people with HIV across England and Wales, and it was the biggest HIV patient survey that's ever been completed at that time. And finally, in 2018, The data from Positive Voices survey had been collected and was starting to be presented, and standards of care were being published for HIV services by our national organization. And at this time, things like quality of life and understanding stigma and discrimination were included in our standards of care for the first time. And then finally, and Jeff will speak to this more in a moment, in 2022, WHO for the first time acknowledged the need to measure things like health-related quality of life in understanding the needs of people with HIV. However, this is 12 years in the making, and we still have no consensus on exactly what tool to use for people with HIV in the services. So I think one of the things we learned is just to start collecting the data and don't necessarily wait for somebody to tell you what the best tool to use is. Use the literature and use the resources and people with HIV to understand what you should collect. And when we did so, we found some really striking, interesting information. So this is a graph showing some of the data that we have on quality of life. Here we use the EQ5D scale, which is a multidimensional scale. It's only 5 questions looking at quality of life. And we were able to use that. It's a generic scale, and it allows comparison with the general population. In doing so, we were able to identify on the bottom section there a big disparity between the needs in people with HIV having a much higher need for issues with anxiety and depression compared to people in the general population. So that was the use of a validated scale, but then we also made up our own scale to try to understand some of the unmet needs. And so a key finding that we found from this was that overall, at the top we'll show you the percentage of patients who had a need in that area, and on the bottom is the percentage of patients whose needs were not met. At the top you can see, unsurprisingly, a vast majority of patients had a HIV-related or health-related need, but also 2/3 had a social or welfare need. When you look at the percentage of needs that were unmet, you saw that most of the HIV-related needs were met. Only 17% of need was found to be unmet. But actually about half had an unmet health-related need that was not HIV, and 71% had an unmet social and welfare need. So in conclusion, I think that there's quite a lot of learning to be taken from other different countries that are doing this work, but I think there's really important to note that measuring patient-reported information like quality of life, stigma, comorbidities is critical now in this era of HIV to understand the holistic needs of people with HIV are met. And there are some general principles for good practice of measurement. It depends on your purpose that you are looking for using it. It depends on your resources, and it depends on the question that you're trying to answer. But what's critical is that you involve people with HIV at each step of that process, and they will tell you what to measure. I'd say probably Jeff and I would both agree that it's important to keep talking about this issue, because with raised awareness, it's taken time to win hearts and minds and get people to understand the importance of collecting this data at a high level, but even at a local level. And overall, don't let perfect be the enemy of the good. So we don't have a consensus on tools that we should be using. That doesn't mean you shouldn't start trying to measure it at your local clinic or at your local services or at the national level. Start and show evidence, show the utility of this data, and that will gather momentum for continuing to collect that data. Measuring something is better than measuring nothing. So that's the end. Thank you very much.